very good evening to all of you. I once again take this opportunity to welcome all my friends, seniors, and the guest speakers who have come all the way from their hometowns and you have joined us. Thank you one and all once again. We look forward to have you more. We look forward to have you quite often. As I have already been warned that we cannot take more than 10 minutes, I would like to start off with my topic. Today I will be going to talk about the thin endometrium and ongoing challenge in ART procedures. In our day-to-day practice, I am sure that all of us would have faced a problem where you are preparing a patient for natural induction, or it could be an IUI or an IVF or a frozen transfer. We end up cancelling the cycle, and it is a distress for the patient as well as the consultant. Then you are in a dilemma because it's a nightmare or a bizarre feeling. Then when you say that patient with everything went fine, at the end of it you're cancelling the treatment, or if there was no success in an IVF, it's just because of thin endometrium. As the name goes, it is challenging from the time it is how to diagnose thin endometrium, what are the definitions, and how to go about it, and the diversity and modalities of treatment available where there is no consensus. So there are different names and entities like poor endometrium, thin endometrium, unresponsive endometrium, and a leptoendometrium in Latin, which also means an unresponsive endometrium where there is no response for the treatment. So today I'll be talking about a normal endometrium or a good endometrium and a bad endometrium, how thin is thin and how thick is thick, and studies saying about the thin endometrium and the causes, evaluation and treatment gradually. So now let me describe a normal endometrium which has got an endometrial cavity surrounded by a functional layer and a basal layer, and outer to that is the inner myometrium. Because endometrium is a dynamic organ or with a huge regenerative capacity which undergoes generation and regeneration during every cycle. So every woman in her lifetime, around 400 cycles of generation and regeneration takes place, and ultimately the goal being that you're preparing an endometrium for a pregnancy, for an implantation or a successful clinical pregnancy in an IVF or an IUI or a natural cycle. It has a huge regenerative potential, as I mentioned, compared to that of a bone marrow, epidermis, or like an intestine. It undergoes cyclical changes during menstrual periods like proliferative phase, secretory phase, and other menstrual phase, proliferative phase, and secretory phase. And they appear, all this description is according to an ultrasound where you see a thin and echogenic line in the proliferative phase, and in a secretory phase it looks more hypoechogenic. And it is normally measured in a free layer in a sagittal section. For a normal clinical pregnancy, it is essential to establish an ideal soil-seed relationship. There has to be a healthy seed and a fertile soil for normal seedling. Similarly, we need a good embryo and a good endometrium to give rise to a good pregnancy. So we are preparing an endometrium where we want to have a window of implantation, which is normally between 19 to 21 days, where the receptivity of the endometrium is very high. So endometrial receptivity during the window of implantation depends upon different markers. Today I'll be talking about only the endometrial marker, which is very easy and reproducible, is ultrasound diagnosis. Basically, thin endometrium we categorize by ultrasound. The window of implantation is between 19 to 24 days. What happens during window of implantation is that increased mitotic activity, increases nuclear DNA, cytoplasmic RNA synthesis to prepare for blastocyst implantation. As I mentioned, different methods of endometrial evaluation is functional biochemical markers, by histology, by ultrasound, MRI, and hysteroscopy. Now I'll be talking about endometrial evaluation by ultrasound. That is more easy and non-invasive methods. The parameters considered are thickness, pattern, and endometrial and subendometrial flow. Advantages of measuring endometrial thickness in an ultrasound is it has got very high negative predictive value, where it is quoted in Fertility Sterility Journal that endometrium of 6 mm or less is associated with 100% negative predictive value. But the limitation being it is poor positive predictive value. Higher pregnancy rates are noted when the blood flow in the endometrium was in zone 3 compared to zone 1, and higher uterine flow rate is associated with positive pregnancy outcome, while absent diastolic flow is associated with no conception. Here I am showing a picture of a pure triple line endometrium in the mid-cycle, a typical 3-line, and it is weak in the fundally and it gradually tapers down. And another picture showing a trilaminar appearance. And here showing the blood flow is zone 1, zone 2, zone 3 accordingly, where zone 3 is supposed to be having a higher receptivity. And this is another picture of zone 3 vascularity. And here I come about the topic. It is thin endometrium, how it appears, and how we go about it. So now, there was quite a lot of debate just to know how thin is thin, how should we categorize, like what should be called, is the cut-off line to call it as a thin endometrium. So there are several studies quoted here, which I do not want to read up because it's going to consume a lot of time. All that I want to say is, all these are studies, endometrial thickness less than 7 millimeter, had no clinical pregnancies, and if at all it had, it was very rarest of the rare cases. So one of the biggest studies where a huge number of IVF cycles were taken into consideration also gave an opinion that endometrial thickness less than 7 millimeter rarely given rise to any pregnancy. So there was a group A where thin endometrial thickness is less than 7, group B is the median category where 8 to 13 millimeter, which is ideal for implantation, and group C where thick endometrium is more than 14. So once I know how thin is thin and how thick is thick, and whether it is good or bad. Endometrial thickness more than 14 millimeter, there were some studies stated that there was absolutely no significance, but some studies did say that if at all they conceived, they ended up in miscarriage. The studies yet to be done regarding the endometrial thickness is very thick. And where is the role of cystoscopy today? Diagnosing a previously unrecognized uterine pathology is one of the biggest advantages of doing a cystoscopy, and 18 to 50% of them reveal uterine pathologies in patients prior to IVF with or without implantation failure and with no prior suspected abnormalities. And coming down to the causes of thin endometrium, once you know the cause of thin endometrium, you know how to treat it. So let me sort out the points like what are the causes for thin endometrium. Main thing is decreased estrogen exposure itself. Second thing is endometrial resistance to estrogen, maybe in the receptor adequate cases, and decreased estrogen exposure in case of anti-estrogens, and reduced blood flow in some cases of vascular diseases, and overexposure of testosterone in cases of PCOD where there is high testosterone levels. And the last one being permanent damage to the basal layer. Either it could be infective endometritis, chronic endometritis, or iatrogenic following in a DNC and abortion, or maybe following in a normal delivery where extensive damage has been done to the basal layer. This is one of the reasons for thin endometrium and no conception. A new theory by Casper RF says, there is a high oxygen tension in the basal layer compared to the thin endometrium. That means embryo is highly toxic to high oxygen tension. In thin endometrium, it is exposed to high level of oxygen in the basal layer, which leads to implantation failure. But still, it needs validated studies. So, but another important cause of persistent thin endometrium, as Dr. Puneet has already said, is very common in our setup, Indian setup, that you will have to think of latent tuberculosis in more than 50 to 42%, where there's complete damage of the endometrium, where absolutely there will be no regeneration. So, coming to treatment, it is most challenging, as we've been saying from the beginning, from the time of diagnosis, finding a cause and treating it is always a very challenging problem because there are no clear-cut remedies or no consensus has been drawn. So let us come to the principle of the treatment. As I said, depending on the cause, it aims at improving the blood supply, increasing the thickness, and increasing the estrogen level, or correcting the underlying pathology. Before I get into the treatment part of it, I would like to quote some studies. Again, there are studies saying, just to say that there is no consensus on any treatment, I would just like to read out this paragraph quoted in an article. Some studies have reported clinical benefits from ascorbic acid, tocopherol, pentoxicillin, or sildenafil for repeated implantation failure in patients with thin endometrium, although the effectiveness and molecular mechanisms by which such agent could improve the implantation process is not well established. Another study says, in a embryo transfer in thin endometrium also says the similar thing, plus along with that about GCSCF and autologous stem cell therapy also, they are all having a poor, unknown and inconsistent results. Studies are on trial. So finally, what again I want to say, there is no clear consensus. But now I'll be talking in detail about each and every treatment part of it. In spite of it being no consensus, I would like to glance at some of the slides here. There's the commonest drug what we use in an fertility clinic or a normal gynecologist, everybody would like to use, first choice is always protein citrate. But we all know that it's an antiestrogenic effect. So, it most commonly used antiestrogenic effect on endometrium, we know it, and pregnancy rates that seem to be less than the ovulation, and 25% end up in abortions. So, to counteract the act of promethyl citrate, either you use an alternative drug, it could be letrozole or tamoxifen, or use estrogen therapy logically, because you know that there is estrogen is less, so we like to use estrogen therapy following the 7th day or during the ovulation, or as good as from the beginning. Again, it's a logical step, but again, dose, type and regimen vary in estrogen therapy also. Here, one of the normal commonest estrogen therapy, what we use stepwise dose, 2 milligrams is given from day 1 to day 4, 4 milligrams from day 5 to day 8, 6 milligrams from day 9 to day 12. It's supposed to improve the blood circulation in the radial artery. Another meta-analysis using estrogen therapy says, ethinyl estradiol 0.02 to 0.05 milligram from 7th day for 5 days. It is shown to improve the endometrial thickness compared to the placebo. Other estrogen preparations like conjugated equivalent preparations 0.625 from 7th day to 5 days. Patches available used in the form of 4 milligram per day till 8th day of ovulation and vaginal local administration of estrogen. Current strategy also says regarding pill management that most patients show adequate endometrial response to estrogen, and it also says the simplest method should be used, or if the no goal was achieved, either you change the route or else increase the duration of the time. Vitamin E, sir, do I have some time? Pardon? Yeah. L-arginine, vitamin E, and L-arginine, all these are the drugs which are basically smooth muscle dilators, increase the blood supply, and L-arginine is more beneficial, supposed to be given in 4 grams, which is shown to increase the receptivity and endometrial thickness. Sildenafil and the different studies used by different people, and they have quoted that there was some benefit. And pentoxifene is another drug. Aspirin, which is used left and right, but still we have found result, but the Cochrane result says there is no added benefit. And the latest talk of the town is GCSF, which I cannot go into detail much. I'll just go through the slides where everybody wants to use now because somehow we want to give a result to the patient. So these are the new drugs available as 300 microgram per ml. And then regarding this pharmacokinetics and the studies involved, and the beneficial effects of GSF on different routes of administration, and few cases have been reported with positive pregnancies. This is how it is used as like an IVF catheter, just like an IVF procedure it is used. And then again, various experimental studies are going on, large trials are needed before concluding it as a very good treatment. Empirical therapies depending on, because immunology is one of the cause for implantation failure. And endometrial scratch, what again the new thing what everybody wants to use. Cochrane data says there was a good birth rate, and then the rationale is inducing destabilization endometrium, giving an immunological aid. So when is it done and all that? It has to be done during the 7 days prior to the onset of menstruation. Just a little scratch, just 1, 2, 3. That's what everybody says. Just a gentle scratch to induce destabilization. Egg freezing can always happen in some patients where unexpectedly you have to cancel an IVF cycle because you have to plan the transfer in the next cycle. During the time you get a time to identify the cause and treat accordingly. Finally, if it becomes refractory, then you end up doing a surrogacy. Again, HCG has a role. It started the 150 international units given from the 7th day. From 7th day onwards, and even it has found to be some improvement in pregnancy rates. Different natural statements are like yoga, acupuncture, and similar. So many things being quoted. You'll find plenty of information on the internet, but still no trials. Nothing has been proved. So what the future holds is intrauterine autologous platelet-rich plasma transfusion and stem cell therapy. Exclusive studies are going on, and now I want to show the ideal candidates. Patients with persistent thin endometrium with repeated implantation failure and treated case of tuberculosis with thin endometrium, Asherman syndrome, greatly are the patients who need the most. There are quoted some studies from very own from our India that endometrial regeneration was found in autologous stem cell transfusion has got a very good success in a IVF cycle. Another foreign study says that intrauterine infusion of these stem cells have really given rise to some results. I would like to conclude by saying that persistent thin endometrium is the most challenging disorder in reproductive medicine. No established treatment yet, the options are limited. Extended estrogen therapy easiest, but it cannot offer for everybody. Other treatments lack options, or all the options lack evidence of utility. More comparative studies are required. Specific studies on specific subgroup. Regenerative medicine is only promising new treatment modality which is under research. Before you suggest something, but they all have to be clinically proven or it should be clinical active. Here I have some few experience and interesting cases in our center. Then one old lady, 30-year-old, presented with menstrual irregularities, and she gave a history of previous cesarean delivery, and the baby was IUD, and after that she never conceived, and she had irregular cycles. Gradually she became amenorrheic for 5 years, and she was diagnosed with Asherman, and she underwent hysteroscopy resection once. After that she presented to us. But when she came to us again, we have tried without bleeding, but we know that ultrasound diagnosis was Asherman, and all the hormone levels were normal. She was given therapy, she never responded. And again, we posted her for second hysteroscopy resection. We put a property, and then she was on hormonal therapy for 3 months. Absolutely no response. Then removed the property and stopped hormone therapy. Everything, no improvement, no withdrawal. Absolutely. Finally, I think we have suggested, and that's the only way left out with us was for stem cell therapy or else adoption at the last resort. Another patient with premature ovarian failure, hardly 30-year-old lady. diagnosis with ovarian failure in the thin endometrium. We did a laparoscopy and she had a very small uterus and small ovaries. We put her on cyclic HRT. Luckily, she was a lady who responded and she had withdrawal bleeding. And now we are preparing for months together so that we'll take her for a big donation cycle. So, what I would like to conclude by saying that all the trials and everything there are no concerns, absolutely still under trial. We would like to know something better from the people who are practicing new regenerative medicine so that we can bring smiles on hundreds of patients and give a 100% success in IVF. Thank you so much. Thank you so much.